We have just 10 more minutes left before the next session, before coffee break. Any questions from the audience?
Hi, I'm Susan from Robart Spaces. Thank you all for your presentations. I have a question for Professor Angeli. As we all know, that China is also an emerging market, just as India is. I know that Chinese government is also taking initiative, trying to attract more private equity into this healthcare service elevation process. However, it seems like people are more interested in their economic returns or figures in the process of building new hospitals instead of considering implementing this salutogenic concept into the design of the healthcare facilities. So I'm wondering, in India, as you shown in the presentation, that some salutogenesis ideas was implemented in the design of the healthcare facilities. So who's taking the initiative of doing this? Is it the government, or is it more of the private entities? Thank you.
Thank you. It's more from the private entity. They are taking this initiative. Reason being, this is now the demand from the customer side. So yes, government is promoting the entire concept of Ayush. So the naturopathy and the yoga and the other therapies to be brought into consideration when treatment is considered. But providing an environment is more from the private partners.
Next question.
I think I stand as well. Good morning. My question is to all the experts in the panel. I'm Calvin Look from Rehab Society, Hong Kong. Personally, I'm very glad to see that the cultural context of your project has become very strong and become very rich in this Congress. It's much richer than the other Congress that I've attended. My question is to all the experts is there any examples in your design that will exemplify the cultural context, or in particular, the alternative medicine, such as Professor Kumar, Professor Mohanty, that you have adopted in India, such as Ayurveda, for Mr. Sparrow, such as Chinese medicine, and for the other projects. So is there any example that can exemplify those approaches in your design or the facilities that you have designed?
Yes. Thank you so much. In terms of example, I can quote Dr. Devi Shetty's hospital as being one of the inclusive design, where he is using low-cost designing measures in which the Indian materials are being used. In terms of his flooring, in terms of his environment, in terms of the garden space or the holistic healing that he is trying to incorporate in the process. The other areas that I could see is in a cardiology setup, which is the Asian Heart Center, where we have yoga and meditation and wellness incorporated as a treatment protocol for the post-operative patients and those on continuation of care. So these are two of the examples I could set from Mumbai City, India. Thank you.
Well, I would say that our experience with Chinese clients is that traditional Chinese medicine and alternative medicine are long-established parts of healthcare in China. So all of our projects incorporate both aspects because the clients want it. So we're doing rehabilitation centers and cancer centers and cardiology centers and even eye hospitals. And at the same time, each of those facilities has a traditional Chinese medicine component. The same customers who want a high-speed CT study for the heart also want to have meditation and acupuncture, and the consumers see it both ways. So the example we showed has traditional Chinese medicine as well as Western medicine.
Also, I might want to add, like for instance, Tai Chi and like the plaza dancing is always a common thing that you have to apply in the exterior activities in all the Chinese projects.
Mohammed?
Thank you. Traditional medicine in South Africa, recently got certain degree of recognition in terms of legislation and also practice. Of course, people are using this traditional medicine extensively, but it hasn't featured formally as yet into the formal type of healthcare facility as yet. But I think there is definitely a space in order to integrate this local and indigenous knowledge into the present scientific knowledge in the society. It will take time, but it is improving as we go on.
What I would like to put forth to the forum here is, are we designing for 20% of the population, or are we designing for the 80% desiring or wanting population? So the burden of disease is on 80% who are not affordable. So can we bring down the design elements to an affordable level of care, which gives them the best of design as well as the best of healing?
Good. Any? Okay.
Thank you.
Thank you. My name is Kato Krasinski, and I actually wanted to kind of build on that exactly. We've got a great panel here standing before us in cross-cultural representation as well as economic opportunity, from luxury development all the way through, struggling with really rural, impoverished areas in South Africa. And I really want you guys to speak to each other, if you would, about this cross-cultural learning. When I was doing research in South Africa, the waiting room behavior was a huge burden for patients in rural South African healthcare clinics. It was, an enormous task to wait through your patient's, visit. And people were expanding on opportunities for maybe a child-friendly clinic where kids can be entertained. So you guys in the States have done research on waiting room behavior and proxemics. In India, you discussed the opportunities for waiting rooms and how to develop and enrich that experience. And as well as in China, there's this pull and this creativity for it. Could you guys maybe lean on each other and how you could use each other to support health-seeking behavior in a sense?
Masood?
I think it's very essential. Firstly, the issue of appropriateness of the technique and knowledge that we are trying to acquire. And secondly, there is adoption into the culture of the environment that we want to apply that. And thirdly, of course, the affordability element and the local material and local technique that needs to be assisting that new approach into that society. I think it's essential. There are wealth of, as I mentioned yesterday, wealth of information in the old culture or tradition needs to be tapped, explored, and to see how it can apply in the modern day society and the need of our society presently.
Simply, absolutely. I think the thing we can't overlook is that being simple doesn't mean not being sophisticated about those interventions that we do make. They don't have to be a high price tag, but they do have to be thoughtful and carefully executed. And I think that if we build off the messages we've heard yesterday, we have to go beyond first cost. I mean, we do know that you talk about community health, we're talking about well-being and lifestyle. Some of those measures won't be recognized in the savings on the first day, but they will be in long-term care that's given and the wellness of the patients that we're trying to seek.
Okay, on that aspect, let me say something very fundamental here. As I mentioned in my presentation, I said in terms of policy or guidelines, call it whatever you want to call it, it doesn't really matter. You have to look at the social contents of the area you're designing, geographical issues, economic issues. Because, like a project now we're doing in Ghana, everything is done by the locals. Materials are done by the locals because you're talking about a space for examination, consultation. It doesn't have to be all imported items. Because in focusing on imported items, locals don't develop at all. So healthcare facilities doesn't need to be 5-star or a space is relative. You can be in any space and have world-class treatment. Space at times can even alienate someone, you know? If you take someone who is not used to being in a 5-star environment, put him in a 5-star treatment, he will never get care he needs. He wants to be in an environment he's used to. So space is relative, and it's not about, I keep on saying, design guidelines has to be specific, you know, or design policies. You have to look at who are you designing for, and you have to ask them, what do they actually need, what do they want? That's very important.
Something that also comes to my mind is we all do life cycle costing of equipments, of facilities, and of buildings. But as an economician and as a clinician, I would like to propose here, can we do a life cycle costing of life itself? Because smaller incremental changes in the quality of life, starting very early on, can reduce the economic burden as well as the per capita expenditure, and it's a win-win situation to all. So that's what I wanted to share.
Okay, I think we ran out of time. Okay, one more question. Okay. And that's the last question because of time constraints.
Hi, I'm Susie from Oricon. I'm going to do 2 questions and be tricky. So one is to the point that you just made around the life cycle perspective. This might be an ignorant question, but is there evidence that has been collected around the impact of salutogenic design on improving people seeking preventative care, as in studying a demographic and seeing that they're actually more likely to seek the care if it's in an environment that is less threatening? So it's one question. And related to contextual salutogenics, I'm interested in the Indian context of technology. One of the first things you pointed out, if that's something that people are seeking more of, is there any research that's been done around salutogenics connected to technology?
Yes. If you permit me, please. Yes. The first question which you mentioned, is there any research? We searched a lot over the last 6 to 8 months whether anyone's been doing a study on impact of design into health, wellness, and prevention. I didn't find any in the open forum. So that's a prospective study which could be looked as a cooperative study. The second question which you mentioned was about role of technology. Yes, this is also an area that can be looked into, because technology per se now is only related to the digital technology or to the accessibility part of it, but not technology as in wellness or preventive care. So this is also an open, where the people don't know about the term salutogenesis and the science behind it, we are trying to promote this knowledge and awareness through our interviews and through our meetings with people. So this is also a prospective area for India.
That's what we call technology translation. Very important. It's a research. Yeah.
And I think in the U.S., what we're looking at is trying to get healthcare out of healthcare buildings, you know, really putting it out in the communities. And I do have a quick story to tell about Good Samaritan Hospital in Phoenix. They put a young cardiologist in a beat-up pickup truck and had him drive through neighborhoods where heart disease was a problem. He came to the patients and they did see a huge change in outcomes by delivering the care in a model that was approachable to the people in the neighborhood.
Just to add on to one thing, we also have something known as home health care. So people who don't want to go to hospitals, the hospital comes to their own house. So you can be in your own environment, and yes, this would impact the well-being of an individual. Faster recovery.
Okay, thank you so much. Now is a coffee break. See you here in the next 30 minutes.